All right, last section of the Neoplasia voiceover.
Metastasis is a hallmark of malignancy. And let's talk now about the American Cancer Society definition of metastasis. Metastasis is the spread of a cancer to a new part of the body. Spread of cancer to a new part of the body is called metastasis. And that spread is totally separate from the primary tumor. As in this example, primary cancer of the lung metastasizes to the brain, a totally separate tumor. One of the things that promotes metastasis is impaired cellular cohesiveness or adhesion. Cancer detaches from its neighbor. This is called loss of adhesion. This process promotes the development of metastasis. A cell separates from the primary tumor and can then invade the blood vessels or the lymphatics and travel to a distant location. This is loss of adhesion. This promotes the process of metastasis. Cancer also has loss of contact inhibition, and that allows for local invasion, which risks metastasis. Normal cells grow in a single layer, and when they contact another cell or an edge, they stop growing. When malignant cells contact other cells or edges, they keep growing and form clumps of cells. You can scroll down and click on this animation to see this process. Cancer can invade and go horizontally, superficial local spread across the surface, or go vertical, downward extension. Certainly, if you invade, there's risk for erosion into membranes of blood vessels or lymphatics, and that risks metastasis. Horizontal versus vertical spread is something that you might find reported on a pathology report. As we've been saying, cancer grows by invasion, and that process of invasion is a factor that promotes metastasis. Cancer secretes proteases or enzymes that allow it to cut into or invade surrounding tissues, including the blood vessels and lymphatics. And cancer can then use the blood vessels and the lymphatics as a way to travel to distant sites. Cancer invades locally, regionally, such as in the lymph nodes, and to distant sites. And that's the concept that I want you to get. If you take care of a patient with cancer in the clinical area, you will look up what local invasion means for that particular malignancy. The image here is prostate cancer. I would never ask you specifically about the cancer, just the concept. Regional, distant metastasis. Again, when you take care of a patient in clinical, you will look up and see what local invasion, regional invasion, and distant metastasis means for your patient. And the American Cancer Society is your best resource for that. Cancer tends to invade and metastasize in a predictable pattern. A person who has a primary cancer of the colon, for example, it would be expected that if that cancer were to metastasize, it would go to the liver. Colon cancer cells break free from the primary tumor, invade the portal vein, and pass through the liver. They then exit the portal vein and seed, S-E-E-D, seed the liver. Colon cancer to the liver is a prototype, but the concept of predictable pattern of spread holds true for most malignancies. Using the reference normal cell, draw a well-differentiated malignant cell and draw a poorly differentiated malignant cell.
Okay, give you a second to do that.
You could draw just about anything you want for well-differentiated as long as it resembles very closely the reference cell. Poorly differentiated, you could draw anything you want as long as it bears no resemblance to the reference normal cell. Poorly differentiated malignant cells are most likely to have metastasized. And why is that? Highly malignant aggressive cells, such as poorly differentiated grade 4, look most unlike the parent cell. Wildly uncontrolled cell division. Tentacles form and invade surrounding tissues. Secretion of enzymes results in local and regional invasion, and then invasion into the blood vessels and the lymphatics, where there is then distant metastasis. Which of these malignant images is in situ and which is invasive? We know they're malignant as a result of biopsy. Which of these malignant images is in situ and which one is invasive? The image on the left is in situ. All the malignant cells lie above the basement membrane. Localized, in place, pre-invasive, in situ. The image on the right shows invasion below the basement membrane. Invasion into blood vessels and lymphatics, which promotes distant metastasis. What do the malignant images have in common? Well, let's just think about that. It's cancer. So a carcinogenic agent triggered the DNA mutation. There's no repair of damaged DNA. Abnormal cells are not kicked out of the cell cycle. There's no coding for apoptosis. That uncontrolled cell growth and growth by invasion is allowing a tumor to get bigger and bigger, locally, regionally. And because cancer grows by invasion, you invade the blood vessels and the lymphatics. That promotes distant metastasis. It's cancer. And how is cancer defined? A second tumor site is noted, totally separate from the primary site. What concept is represented here? Primary lung cancer has spread in a predictable pattern. There is evidence of distant metastasis. And again, how did we know the primary lung cancer was there? The result of biopsy. Metastasis, a hallmark of cancer, the role of tumor angiogenesis in tumor growth and metastasis. Cancer is a living thing. It requires a blood supply. In order to meet its need for oxygen, nutrients, and the elimination of carbon dioxide and waste products, blood vessels need to grow into the tumor. The tumor puts out growth factors, which causes new blood vessels to sprout. And those sprouting blood vessels can also serve as a route for distant metastasis. Click on this animation.
Oops. I was going to show you the animation, but I think it is not working that well, so we're just going to skip it. I think it's not working well because there's user error.
Angiogenesis also can play a role in treatment. If you can block angiogenesis, if you can block growth factors, you can cut off the blood supply. Cancer is a living cell. Without oxygen and nutrients, it will die. Cancer as a disease is immortal, but individual cells will die if the tumor outgrows its blood supply, and this is called a necrotic core. The cells have died in the center of the tumor, and this is a terrible thing. It means that the cancer is very aggressive. The cancer is growing more quickly than it can generate a blood supply. A necrotic core is not a good thing. It often represents a very aggressive cancer. When we talk about where a cancer is found in the body or how far it is spread, we call that the stage. Staging is determining the degree or the extent of cancer spread, the degree of invasion, and the degree of metastasis. Staging is the degree of anatomical spread. So stage 0, which is in situ, would be most local. It's all above the basement membrane, pre-invasive, stage 0. And the stage is named by the degree of anatomical spread. So stage 4 would be the most distant. I want you to understand the concept. Stages can vary depending on individual cancers. So again, when you take care of a patient in clinical, you will go to the American Cancer Society homepage or some other site and determine what the stage means for the patient that you are taking care of. Staging is the degree of anatomical spread.
And here are some pictures that show you stage 1, 2, 3, and 4. And this is in a prostate.
Metastasis is best described as
A. Invasion of cancer below the basement membrane. B. Secretion of enzymes. Cancer works its way into the blood vessels or lymph. C. The result of uncontrolled cell division. Or D. Cancer spreading beyond the site of origin to a distant location. And the answer is D.
cancer is best described as cancer spreading beyond the site of origin to a distant location. Invasion below the basement membrane contributes to metastasis. Secretion of enzymes contributes to invasion and contributes to metastasis in that the blood vessels and lymphatics are invaded. Metastasis is often the result of uncontrolled cell division that makes the tumors large enough that they invade and then metastasize. But if you're going to talk about metastasis as a definition, Metastasis means cancer spreading beyond the site of origin to a distant location. When a person is diagnosed with cancer, it is important to determine where in the body that cancer is located. And the workup is called the staging workup. Where has the cancer spread in the body? And the staging workup is based on the predictable pattern of spread. So we want to know, has the cancer spread beyond the primary site? A variety of diagnostic tests can be done. Magnetic resonance imaging can be done. Computed axial tomography or CAT scanning can be done, where many pictures are taken to determine the location, the size of tumor, and whether a tumor can be found anywhere else in that person's body. Staging also includes determining whether the lymph nodes are involved and how much of the surrounding tissue is involved. And that is determined during surgery. The surgeon will sample lymph nodes and will sample surrounding tissue to determine the presence of a malignancy. Has the malignancy invaded beyond the primary site? Surgical staging of cancer is reported as the TNM, where the T stands for the size of the tumor, the N for lymph node involvement, and the M for any evidence of distant metastasis. The TNM report converts to a stage, TIS, NO, MO, or X. This is stage 0, tumor in situ, and you'll notice that all of the malignant cells lie above the basement membrane. No lymph node involvement, no distant metastasis. Stage 0, adenocarcinoma of the breast. The word that tells you it's malignant is adenocarcinoma. Carcino is a malignant word element, malignant epithelial tissue. The words that tell you the stage, in situ. Stage 4 breast cancer at the time of diagnosis, T2, N2, M1 or positive. The higher the T, the larger the malignant tumor. The higher the N, there's increased numbers of lymph nodes involved. N2 doesn't mean 2 nodes, it means 2 groups of nodes. M1 or positive, evidence of distant metastasis, bones, brain, or lungs, based on the concept predictable pattern of spread for breast cancer. Staging is determined at the time of diagnosis. So, for example, this person has colorectal cancer, stage 3 at the time of diagnosis. Several years down the road, there's evidence of liver involvement. This is now stage 3 with changes in size of tumor, additional spread. The stage of the cancer doesn't change. Staging is determined at the time of diagnosis. Let's do some more review questions. Surgical staging is done for 3 of the following reasons. Surgical staging is not used to
I'll give you a second here.
Surgical staging is not used to determine tissue differentiation. That is grading, putting the tissue under the microscope and answering the two big questions. Number one, is it cancer? And number two, what's the grade? Differentiation, how closely does the malignant cell resemble the cell it was supposed to be? That is grading. Staging is the degree of anatomical spread. And staging during surgery samples lymph nodes, samples tissue from around the tumor for invasion, and will establish the TNM, the size of the tumor, whether there are lymph nodes involved, and distant metastasis. A person is diagnosed with stage 3 cancer. Which of the following has to be true?
Remember, on these questions, just feel free to stop the presentation while you think about the answer.
A person is diagnosed with stage 3 cancer. Which of the following has to be true? It has to be true that the cancer has moved or invaded beyond the primary site. It could be true that it's a T2, malignant tumor. It could be true that it's N1, one group of lymph nodes involved. It's not likely that it's grade 2, moderately well differentiated cancer. A stage 3 cancer has been around for a while. It's more likely that the tumor would have a higher grade, like a 3 or a 4. But stage 3, the cancer has moved or invaded beyond the primary site. A person with a new diagnosis of lung cancer has an MRI of the brain. A tumor is noted. Which of the following is most likely to be true? It is most likely that the primary cancer is stage 4, based on the concept of predictable pattern of spread. Cancer of the lung is known to metastasize to the brain. At the time of diagnosis, the TNM is reported as T3, N2, M positive. How would you interpret this report? The primary cancer is stage 4. And how did I know that? Because of the M positive. Anytime M positive or 1 is present, that means distant metastasis. It's an automatic stage 4. I don't know the type of cancer, it's not listed. And I would suspect if you have a metastatic cancer that is stage 4, the cells are not well differentiated. It's more likely they would be a poorly differentiated grade 4. And the N2 doesn't mean 2 nodes, it means 2 groups of nodes. So that M positive automatically tells you that the primary cancer is stage 4. At the time of diagnosis, the pathology report says adenocarcinoma, T3N2 M positive. How would you interpret this report? The word adenocarcinoma tells you this is an epithelial tissue cancer. And again, T3 doesn't mean 3 centimeters across. It is a large tumor. T3 is defined differently for different cancers. You would look that up in clinical. And as we said before, N2 does not mean 2 nodes, it means 2 groups of nodes. And it would be highly unlikely with a T3N2 M positive stage 4 that the cells would be well differentiated grade 1. It would be much more likely they would be poorly differentiated grade 4. So let's write a report that suggests a better prognosis for persons with a malignancy. We would like to see grade 1 well differentiated. It's malignant, but it still looks a lot like the cell it was supposed to be. And assuming that we couldn't get tumor in situ, T1, a small malignant tumor, no lymph nodes, and no distant metastasis. In fact, the tumor was so small, you wouldn't even look for distant metastasis. And that would convert to a stage 1, which generally has a good prognosis. And where do you go to find information on specific cancers? The American Cancer Society homepage is a wonderful resource. This young gentleman is asking, I've heard that some cancers are said to be more aggressive. What does that mean? There are certain factors that contribute to aggressive malignancy, the most important of which are the genetics of the malignant cell. So not even all cancers of the same type are equal. The genetics can be different and can affect how quickly the cell grows and metastasizes. Cancer cells also have the ability to engulf or eat certain molecules that deactivate tumor suppressor genes. And if you deactivate tumor suppressor genes, you don't suppress tumor growth. And cancer cells can divide and divide and divide. Can you catch cancer earlier? Are there earlier signs of possible malignancy that may be found during routine screening? Pap testing is a common screening test for cervical cancer. The cervix opens to the outside, making it available for testing, so that cervical cancer can be diagnosed early. When we talk about reproductive disorders, we'll talk about the pros and cons of breast self-exam, testicular self-exam, and digital rectal exam. There are some pros and cons for each of these screening methods. There's no substitute for mammogram when it comes to screening for breast cancer, and that's true for both men and women. Screening mammography is usually started at age 40 in today's world. unless you're a high-risk person, and then you would screen earlier. Colorectal cancer screening used to begin at age 50, and now it's age 45. Screening colonoscopy to pick up the earliest changes that could be suggestive for colorectal cancer. Removal of polyps and biopsy reduce the risk for colorectal cancer. Skin inspection has been controversial, but the current recommendation is that evidence is insufficient to assess the balance of benefits and harms of visual skin examination by a clinician to screen for skin cancer in adults, assuming that you are asymptomatic. Skin inspection has been controversial, but the current recommendation is that evidence is insufficient to assess the balance of benefits and harms of visual skin examination by a clinician to screen for skin cancer in adults, assuming that you are asymptomatic. Later manifestations of cancer are based on the increase in size of the tumor, and there can be local signs and symptoms or systemic signs and symptoms. Local signs and symptoms, local manifestations, are often those related to obstruction. So, for example, in this case, you're seeing the esophagus of someone with esophageal cancer and adenocarcinoma. We don't screen for adenocarcinoma of the esophagus. So when it often presents obstructive. Now, do we screen people who are at risk for adenocarcinoma that have GERD, gastroesophageal reflux? Yes. But we don't screen the general population. Systemic effects of cancer can include cancer cachexia syndrome, as outlined here. And this is seen most often with cancers of the GI tract. Notice the amount of muscle atrophy and the loss of subcutaneous tissue. Weight loss greater than 10%. That's unintended weight loss, greater than 10%. Mortality in persons with advanced cancer is often related to loss of organ function. Remember, malignant cells neither look like nor perform like normal cells. This individual has a liver that is loaded with cancer that can't perform the function of a hepatocyte. The mortality in persons with advanced cancer is often related to loss of organ function. So what are the categories of treatment for cancer? And this will just be an overview. If you have a solid tumor, surgery plays a key role in the removal of that tumor. And when a solid tissue cancer is removed, how do you know that you got it all? The tissue that's removed is sent to the pathologist, and hopefully the pathologist will say, the tumor is surrounded by a nice amount of healthy tissue, meaning the tumor is embedded in the tissue that was removed, that there's no tumor sitting at the edge or margin of the tissue that was removed. That means you probably got it all. Free surgical margins. Remember that staging is the degree of anatomical spread, and surgery will help determine that stage. In this case, the surgical margins are free of tumor, and the lymph nodes were biopsied and they're negative for cancer. The reported T2NOMO. The stage would likely be high or low. It would be low. And the risk for metastasis would be low. No lymph node involvement, no distant metastasis. Surgery stages the malignancy and gives you the TNM, the size of the tumor, and whether or not there's lymph node involvement. And distant metastasis may be assessed at that time. Radiation therapy can be disruptive to cells in the process of synthesizing DNA. Some malignancies are radiosensitive. Certain cancers are historically responsive to radiation therapy, meaning the radiation will disrupt the DNA in rapidly dividing radiosensitive cells. Chemotherapy can also disrupt cell division in various stages of the cell cycle. This particular person has a port embedded in the subcutaneous tissue so that they can receive chemotherapy. Click on this YouTube video to learn a little bit more about chemotherapy. Immune therapy can also be helpful in the treatment of cancer. Click on this YouTube video and learn a little bit more about immune therapy.
So make sure that you take a time out and watch those on your PowerPoint lectures. More technical issues here.
In today's world, you hear a lot about the concept of precision medicine. In this case, precision medicine oncology, choosing the right treatment based on the genetics of the cancer, targeting the specific mutation and type of cancer. That's where the future lies in the treatment of malignancies.
All right, great job, guys. We made it.